Good morning and welcome to our Facebook Live session here. My name is Dr. Rob Cunningham. I'm a general and bariatric surgeon. I recently joined the practice here at KC Bariatric and really delighted to have joined an excellent practice here. We're really doing some great things for a lot of patients, and we're looking forward to seeing hopefully maybe some people watching and joining us this morning in the office maybe in the near future for a consultation. So the first couple of weeks after surgery can be kind of tough going, especially you can be a little bit sore with your incisions. It can be kind of tough going to get fluids down and get things like protein shakes down. Oftentimes people may actually be up a couple of pounds. Usually that's due to some fluids that you've gotten around the time of your operation and immediately afterwards. We give people a lot of IV fluids to try and reduce the rates of dehydration in the first couple of weeks after, because that can be quite a common problem. People will often notice, particularly if you have diabetes and your sugars have been high, those should hopefully be improved very quickly after surgery, sometimes within 24 or 48 hours, that your insulin requirements or your medication requirements can be a lot less. Weight loss will come. It's not uncommon for people to notice a plateau at 2 to 3 weeks. In the vast majority of cases, once you kind of get beyond the 1 month mark, some really great things start to happen, both on the scales and in how you're feeling afterwards as well. So for the two primary operations that we offer, which is the sleeve and the bypass, we treat both of them the same in terms of how patients are managed around the time of the surgery. They essentially have the exact same incisions. The incisions hurt about the same after both surgeries. Usually most people notice that the one on the left side is the most uncomfortable one. And the reason for that is usually we need to put a stitch in there to reduce the risk of a hernia afterwards. And that's quite deep down, and that can occasionally cause some pain for a few weeks afterwards. And that's the most common spot that people have trouble with. We do numb it up at the time of surgery with some local anesthesia, but that can wear off and it can be a little bit sore, but often that's controlled pretty well just with some tablet medications. The first couple of days afterwards is generally just a liquid diet before you get back on things like protein shakes, and very slowly introduce some soft solids after that. There's a lot of detailed information in the booklet that every patient gets before surgery. I ask everybody to read it twice, cover to cover, and generally about 98% of your questions will be answered, and that is very specific in terms of the first few weeks afterwards. In terms of medications then, those are generally tailored depending on what you have come in on. So everybody afterwards gets some blood thinning medication shots, generally Lovenox, for about 7 days afterwards. That's to reduce the risk of clots, particularly in the legs afterwards, which can be an issue if that medication is not given. We send everybody home on anti-acid medications, particularly after bypasses, in order to protect the anastomosis, where the pouch is hooked into the intestine. And they're usually for at least 3 months afterwards. Sometimes we'll continue those for a little longer in certain situations. And then everybody gets some pain medications and some anti-nausea medications as well. So we usually tablets Zofran, and that can help to allow people to get more fluids down, especially if they're feeling a little nauseous after their surgery. And then in terms of other medications, that's on a case-by-case basis, unless they're on insulin, which will often at most be a half dose, and sometimes not at all, and we'll just get people to keep a pretty close eye on their sugars afterwards. But generally it's hopefully less medications in terms of your long-term medications than you came into us with. I've noticed a lot of people in the office are concerned about diarrhea, particularly after a bypass. And in fact, really in the first kind of couple of weeks to a month, oftentimes constipation is more of an issue, and there's a couple of reasons behind that. One, it is kind of easy to get a little bit dehydrated or not be able to hit your 64 ounces of fluid goal a day. And the second is the pain medications. So any narcotic pain medications do have a side effect of constipation and slow the bowels down. And then thirdly, there's not a huge amount of fiber in that liquid diet, both prior to your surgery and the first couple of weeks afterwards. So I kind of call it like the triple whammy of things getting backed up. But the good news is you can pretty much take all of the usual constipation medications, and that won't cause any significant issues with either your sleeve or the bypass afterwards. Oftentimes it does take a couple of days for that first bowel movement to come. I'd say most people at their first week visit will say, it took me a while, I only went yesterday, and they get a bit concerned. That can precipitate a few phone calls, but that's pretty common and usually not a major issue. Oh, well, first of all, congratulations. You've met and exceeded your own goals, which is really commendable. That is a really tough thing to do. Losing weight, but also keeping it off is really one of the more challenging things. So congratulations, really, first off. In terms of adding a keto diet to bypass anatomy afterwards, there's certainly no issues with it. I know from personal experience in my household, my wife is fond of the keto diet, and it can be restricted in certain aspects. There's no problems with adding it afterwards. It's not necessarily strictly necessary in order to keep or maintain weight loss. Certainly it can be added on as an adjunct. The key thing is, portion control, regularity of meals, avoiding snacking is really one of the key aspects in order to maintain weight afterwards. And avoidance of very calorie dense foods, so really highly processed, highly sugary foods, particularly as snacks. That's where a lot of people can run into some trouble and some weight regain afterwards. Particularly after about the 1.5 or 18-month mark, that's where most people will hit their lowest weight afterwards. So good for you, and keep up the good work. Ulcers are a problem particularly associated with gastric bypass. We generally don't see them much in our sleeve patients. And there's really, I kind of keep it pretty simple. There's really 3 precipitating factors for ulcers after a gastric bypass. The first one is smoking. Smoking and bypass they do not mix. Smoking tobacco, cigarettes is just absolutely not advisable. That will lead to lots of heartache, both for the patient and for us, because we'll be seeing a lot of each other, unfortunately, in that circumstance. Other things that can precipitate ulcers include use of non-steroidal pain medications. So commonly would be ibuprofen, Aleve or naproxen. They're pretty commonly used for migraines or headaches, people. And we do see some people a couple of years out who've kind of forgotten perhaps that those are really not good. And so smoking causes reduced blood flow, particularly to that segment of the intestine just after your anastomosis ulcers, or where your pouch is hooked into the intestine. And the lining of the bowel really does not like that reduction in blood flow. And then the non-steroidals are very irritating. So non-steroidals were commonly caused gastric ulcers back in the 80s and 90s, before we had really good anti-ulcer medications and before we knew that H. pylori caused trouble down there. And then steroids is the other thing I tell people, prednisone. So people who take it for rheumatoid arthritis or COPD, that can cause issues or irritation to the lining of the intestine just after your pouch. It's generally right at the very end of the pouch, or just after, where people can get ulcers there. In most cases, all we need to do is do an endoscopy, have a look and assess what things look like down there. And then it can be a fairly hefty medication regimen to get those healed up. But it usually takes about 2 or 3 months. But in most cases, they will settle down, as long as all the other things fall into place, etc., like smoking cessation. Occasionally, we do need, for full disclosure, we do need to do occasionally some operations if those ulcers are just not healing, in order to get rid of the area that's not healthy. But that's relatively rare, and we do those operations if people are having trouble. The jury's a little bit out on this. I guess really from a personal circumstance, I think it's best to avoid, particularly ones that have nicotine in them. All vaping requires some degree of combustion, though it may not be burning the end of a cigarette. In order for you to generate a vapor that's inhaled into the lungs, there has to be a degree of combustion. And so all of those, there's a whole bunch of chemicals in there that are generally pretty bad for your lungs. And this was discovered early in the COVID pandemic, that vaping predisposed people to bad outcomes with COVID. And that's separate to bariatric surgery, but I'm using that just to illustrate the point that the chemicals that are generated are probably not very good for you. We haven't seen such an issue with ulcers with vaping as there has been with smoking, cigarettes and tobacco. But I guess for overall health and improvement, we would generally counsel people to avoid it if at all possible. Usually most of the weight loss is done in the first 6 to 8 months, somewhere in that kind of rough ballpark, that the curve really heads downwards. Usually after that mark, weight loss will continue, but it happens at a slightly slower rate. And then usually the lowest point, if you were to draw a curve of your weight after surgery, is somewhere around a year and a half afterwards. You know, the real power of this is in the first year to year and a half. And the most you can do in that time will really tee you up for success down the road and to really keep as much weight off as possible. After 18 months, there's always a little bit of a weight rebound, and that's generally not through any fault on the patient's behalf, as long as, you know, eating behaviors and exercise, all the other adjuncts that are very important to maintaining weight. What I liken it to is like a thermostat. Your thermostat has kind of a set range or a point that it likes to be in, and the body has its own internal weight thermostat, for want of a better expression. And when we turn that all the way down with surgery and a very strict diet, there's always a little bit of a natural rebound, and that generally seems to occur somewhere after about a year and a half. There's a little bit of a reset of the happy zone that the body likes to be in, and then really at that point it's about maintaining at a hopefully a much healthier weight after that. And on top of that, all weight-related comorbidities like diabetes, heart disease, all those sort of things have improved, like blood pressure, etc. Oftentimes, when we see patients in the office, there is often some component of reflux. Often that's teased out pretty quickly in that people have adapted their eating behaviors to either avoid reflux or compensatory things. Oftentimes we find people eat kind of high-calorie foods, stuff that goes down really easily, and unfortunately sometimes can contribute to some weight regain as well. So those two often, not always, but often go hand in hand. I think in that particular situation, you could always come in and talk to us in the office. There are all sorts of payment plans, and even for a brief chat, our finance department is very flexible, and there are other options available on the market in terms of additional insurance and coverage depending on your employer. There are bariatric specific plans that can sometimes be put in place to provide particular coverage for something like a revisional surgery. If people have no other options, we do also offer a cash pay option that can be done in installments. Probably the best bet is give our office a call. We can get you through to our finance department, and we'd be delighted to see you in the office and see what we could do for you. Certainly don't want people to fall out of the program or feel that they've done something to themselves, or they've kind of undone the good work they've done. There's always something that can be done. If a revision is not potentially an option, we do offer an excellent medical weight loss service through our wonderful nurse practitioners, Mary and Selena, who can do a comprehensive assessment and see if there's some medical therapies that could be used to provide an additional boost. That could be considered like a primary care type visit. I don't want anyone to think that there's nothing that can be done at all. Right. We'd be surprised how inventive we can get with getting stuff covered for people. So I don't like to focus too much on the raw numbers sometimes, because that can tee people up a little bit if they don't quite meet goals, or they set a very strict goal. Can lead to a little bit of disillusionment. I think there's more to it than just the raw numbers, although they are sometimes a helpful metric to use. In that particular circumstance, if you're immediately post-op, the key things I would focus on are making sure you're staying hydrated, meeting your fluid goals of about 64 ounces a day, hitting your protein goals of about 60 grams a day. That's a pretty rough ballpark, but that's generally what we recommend, making sure the protein shakes get in. And if you're over a week out, probably making sure you're on your multivitamins and making sure you're taking all those things. Those are the key things in the first kind of month or two afterwards, to really make sure you're focusing on. Everything else should hopefully fall into place pretty well. Frequent question in clinic, and something I cancel all female patients who are...
Cancel or counsel?
Cancel. No, don't cancel anything, no. No, I cancel everyone about that as part of the pre-op, particularly for premenopausal females. And that includes up to generally about age 50. So just because you may be in your 40s, you may be done with family planning, that does not, you are still included in that discussion. And we recommend strongly to not get pregnant is the simplest way to put it for the first year or 12 months after bariatric surgery. There's a couple of reasons behind that. One, your whole system is in what's called a catabolic state, where you're burning a lot of calories, particularly with a bypass. There is some component of some malabsorption as well. Your body's undergoing a lot of hormonal changes, which happen pretty much almost immediately after your surgery, but the effects can last quite some time afterwards, up to a year or even 18 months afterwards. In addition to what I've mentioned, the multivitamins, we would have to make some changes to that. There may be some additional changes to medications and things like that would just be preferable to avoid getting into that circumstance if possible. So I counsel every female patient that potentially could be an issue for, just make sure we've had the discussion, take appropriate precautions. It can make life a little bit tricky. So in order to make everything nice, smooth sailing, afterwards, we generally avoid it. And also there is some weight gain associated with pregnancy, which it certainly won't undo any of the good work that we've done with the operation, but it can certainly slow down the weight loss afterwards. Particularly younger women come in they have polycystic ovary syndrome, and they've had trouble with fertility and may have undergone IUI or IVF or something prior to seeing us in the office. There's a good chance that'll get a lot better afterwards. But that can happen very quickly within like a space of 2 or 3 months, even without significant weight loss, just that little initial bit of weight loss and probably some positive hormonal changes as well. And while on the face you would say, oh, isn't it wonderful that you got pregnant when immediately after surgery, we're sensitive to the fact that unplanned pregnancies are not always the most welcome news to everybody, depending on circumstances. So I think it's usually wise just to have conversation and discussion, knowing that this can be a benefit afterwards. So that's a particular circumstance. So type 1 and type 2 diabetes are, while they sound much the same, they're totally separate kind of disease processes. Obviously, type 1 diabetes generally starts a lot earlier in life, and it is an insulin-related issue as opposed to an insulin resistance issue. But certainly it sounds like things went pretty well initially. That is maybe a particular circumstance that we would maybe want to see you in the office. Our nurse practitioners, we're plugging them again here. Mary and Celine are excellent about kind of figuring out if there's anything else that can be done with medications. Some of the newer medications, weight loss medications on the market that have just come out in the last 12 months and are FDA approved. I'm not going to mention, I don't know if I'm allowed to mention names or not for commercial reasons. I've certainly no commercial interest in them specifically, but they're actually primarily diabetic medications, but they have a side effect, certainly more recent ones, of some significant weight loss as well. That can actually be an excellent adjunct at this point if there's been some plateauing or some weight regain, to add in those medications at this time, sort of part of a back on track type strategy. And then also visiting with our dietitians to do a comprehensive dietary assessment and see is there any room for kind of improvement at that point as well. We're always happy to see people back in the office on the surgical side as well, but we generally like to have all the other bits and pieces in place in terms of the diet, additional medications, and if we're not quite getting to goal in terms of a comprehensive approach, we could certainly look at if there's any revisional procedures that might be an option as well. I'll preface that by saying that this is an active area of research in the kind of bariatric and surgical world. And the very short answer is we have not fully figured out all of the changes that actually explain how bariatric surgery works. In very kind of broad terms, there are several different hormones that relate specifically to eating and satiety. Some of the ones that are more commonly known would be leptin and ghrelin, and they were discovered back in the 90s, and they were thought to be kind of the holy grail of weight loss. And if we could manipulate these with medications, then we could kind of fix obesity and diabetes and things like that. As with many things, unfortunately, in medicine, that hasn't quite worked out as easy as that, because unfortunately it's actually a lot more complicated than we realize, because there are hormones changing, different hormones that both promote satiety and slow down intestinal absorption, and they change by different amounts at different times and depends somewhat on the operation as well. So for example, after a sleeve, there's not not as many changes with the gut-specific hormones. It's more to do with the stomach hormones and ghrelin and leptin and things like that, as opposed to like the GLP-1 hormones that are manipulated by the GLP-1 medication. So without getting too lost in a science background of it, in terms of specifically for female patients, we did mention a little bit about some of the changes as regards polycystic ovary syndrome. Generally, there should overall, in a broad concept, be a reduction in the excess estrogen, which is probably one of the mechanisms by which polycystic ovary syndrome is improved afterwards, with significant loss of fatty tissue or adipose tissue, which is the primary source of estrogen in all of our bodies, but particularly in females. That reduction afterwards can, first of all, improve polycystic ovary disease, in addition to all the heart benefits, blood pressure, diabetes, that there's been a reduction in cancer incidence, particularly cancers both in men and women that are driven by excess hormones such as estrogen. I've had many patients actually say that to me directly.
So I think the nurse practitioners have said that patients felt maybe a female to female thing.
Potentially, yes. I'm aware that my gender may preclude me from some of female patients being as open about those things. So I guess there could be a couple of things driving that. Certainly, I think a good chunk of that may be hormonal fluctuations. Very few things, particularly after a bariatric surgery, happen in a very linear or straight fashion.
So tell them why.
We don't use that word crazy. We're not. That's not a word we use around here. That's like the FAT word. That's a bad word in this office. We do not use that for anybody here. Most of our patients are female. Probably about 3/4 of our patients which are female, and probably most of those are premenopausal. So bearing in mind your cycles will continue afterwards, of course, depending on if you're using contraception or not. So some of those changes may be exacerbated, particularly with some weight loss, some either estrogen release or excess estrogen, being removed from the system essentially. But the other thing to bear in mind too is that a lot of our patients do have some underlying, generally hopefully pretty well controlled psychiatric conditions as well. That certainly does not preclude them from getting surgery, but there can be both changes in those that are related to hormones, so changes in mood levels, but also medications. There can be some changes in absorption, whether some medications are getting absorbed a little more or a little less or a little more quickly, and sometimes dose adjustments do need to be required both up and down. That is kind of on a case-by-case basis, but certainly, if temporary fluctuations would be fairly common, but obviously any significant, depressive episodes or anything, we have an excellent psychological support team here, Dr. Ravi and Dr. Michelle, who are available to help with that in conjunction with any physicians who might be treating you for those sort of conditions outside of here as well. Not very common. We do say probably less than 10% of people with sleeve will run into trouble. And that specifically is due to the fact that when you take a large portion of the stomach off, which is what happens with the sleeve gastrectomy surgery, the remaining stomach is not quite as stretchy as the previous stomach, and that can mean that the pressure in the stomach is a little bit higher than it was prior to your surgery. And because food moving down your esophagus or your food pipe into the stomach relies on pressure changes or differentials essentially, once you remove some of that or you balance up those pressures, things can start to back upwards, particularly when people lie down at night. They notice it's precipitated by heavy spicy foods, spicy sauces, things like that. Sometimes it can be controlled on medication, sometimes the medications aren't enough. The bypass, by contrast then essentially, because you're disconnecting the vast proportion of the stomach from the very bottom of the esophagus, you're really essentially left with about an egg or an egg and a half volume of stomach pouch. Important to remember, in the bypass we don't take out any portion of the stomach, we simply make it into two, a much smaller part which is up top, and that's the pouch, but the remainder of the stomach is left in the belly. It's not taken out, but most of the acid production is further down in the stomach. So any acid that is made by the stomach will just drain down through the bottom of the stomach, and because it's not connected to the esophagus, essentially there's no way for that acid to get back up into the esophagus and cause heartburn or reflux afterwards. There is no judgment in our office here. Our psychologist, Dr. Ravi, mentioned recently that a patient came in to say that it was the first time they'd come into a medical setting and felt like they weren't judged for their weight or any other associated comorbidities. So we're here to help for primary operations, regardless of what the goal is. If it's just weight loss, diabetes, there's a long list of medications or blood pressure meds that we need to help with. We absolutely can help with a lot of that stuff. If people are having trouble with reflux after sleeves, bands, there's still quite a few bands, gastric bands floating around there in the community. We do not put them in anymore. Unfortunately, that the bands didn't really work out quite as well as planned back in the 2000s. So we're more than happy to help with all of those. And I want people to be reassured that certainly no one's turned away. We take all insurances here. We work with everybody to keep the costs as minimal as possible. And we like to feel that there's no issue we can't tackle in some way, shape, or form, or get you referred to a particular person if there's a particular issue we feel we can't deal with.
Great.
So, thanks so much for everybody's time. It was great to talk with everyone, and I look forward to seeing you in the office.